So I'm Tabitha Randell. I'm a paediatric endocrinologist. I've been in Nottingham for 20 years, pretty much exactly. 10th of October 2005, I came here. And I'm going to talk about the hormone problems that you get after treatment for cancer and a little bit about what we do about it. So I'm going to give you a whistle-stop tour of hormones and then just finish up by telling you what we've done here. If anyone's got any questions along the way, please feel free. I've checked it's okay to stop me and ask me en route rather than doing questions at the end, because I know that you can never quite remember what it was you wanted to ask. So why do we need hormone input? Endocrinology, that's the study of hormones. And what I see in the clinics I do along with my oncology colleagues is lots of different primary tumours and cancers that can cause hormone problems. And the actual underlying condition itself or the treatment that you have can result in long-standing hormone problems. And the commonest ones I see are listed there. So you can have problems with making growth hormone, you can have problems with your thyroid, you can have problems with your puberty, whether that's going too early or too late or not happening at all. You can have problems with being able to produce enough of cortisol, the stress hormone, and diabetes insipidus, water diabetes. That tends to mostly be due to the actual tumour itself rather than the treatment, although it can arise after surgery. I'm going to talk about the main hormones. I'm not going to particularly talk about diabetes insipidus at all today, but I'm willing to answer questions. Has anyone got any? So the majority of children I see and young people I see in the joint clinic have survivors of brain tumours, and I can see some of my graduates in the audience today. And so this is just a bit of a schema showing what happens after you've had, particularly after you've had radiotherapy. And this is just a little demonstration of what is likely to happen to your hormones and how long it takes to happen. So on the up here, your probability of having your hormones normal. So 1 is completely normal, 0, you've got nothing left. And then along the bottom, you've got how many years it takes before you'll see the changes. And you can see that after you've had radiotherapy, pretty much everybody is going to end up growth hormone deficient. And certainly within, oh, what's happening there? TV's going to turn off in 1 minute. Due to the TV's auto power off, press any button except the power button. Okay. I don't know where those are. Fine. I'll go to the next slide. But yeah, so you can see growth hormones are most likely to go, followed by the ACTH, which controls your stress hormone, then your puberty hormones, and the TSH, which is the one that controls your thyroid, is the one that sort of hangs around longest. And depending on how much radiation you've had depends on how long it takes and how likely you are to end up with growth hormone deficiency. So if you've had more than 50 Gray, you're going to end up growth hormone deficient. And yeah, by 5 years, basically, if you had more than 50 Gray, you aren't making growth hormone anymore. Yes. Does that depend on whereabouts you were radiating? So if you've had what I'm talking about here is if it's your head and spine. So if you've had 50 Gray of radiation to your head and spine, you will end up with growth hormone deficiency. And this is just an example of a growth chart showing what growth hormone deficiency looks like when you're growing. So if you aren't making enough growth hormone, as well as being small for your family, you also don't grow. So what you can see here is the young person falling away from the thing that, so falling away from the chart, and then the little dot there is starting growth hormone, and you can see they've caught back up. The other thing is that growth hormone isn't going to make you any taller than you would have been for your family. So if you're from a not very tall family, you're not going to be a very tall person. And crikey, it's just not quite the right, different distance here. What we can see, so what were these marks here? This is telling you, this is where this young person's expected height would be from his parents. So when we're assessing how tall someone should be, we need to know how tall your mum and dad are. It's very important that we measure your parents, because mums mostly know how tall they are, because we usually get measured when we're pregnant, and all dads are 6 foot, without fail, always. And I'm 5'9", and I often wear a heel. And so I will stand up and I'll say, okay, so where would little Johnny's father come up to me. Invariably it's here, and so I write 5'5". But yeah, so it's quite important to measure them. And it's not just for your growth. You need growth hormone for your bone strength. You need it for your muscle strength. And it's also really important for your general well-being. You feel rubbish if you haven't got enough growth hormone around. Actually, some people don't notice, but one of the things I've noticed over the years, so when you finish growing, we want to reassess to see, do you still need growth hormone as an adult? Because you still need a bit, even if you finish growing. And some young people come back because we have to stop it for a few weeks before we reassess them and say, I have just felt so depressed and miserable and exhausted, and not having enough growth hormone can really impact on your well-being. It has to be given by a daily injection, which can put some people off, but there is a new preparation that's once weekly. So for people who really, really hate having a growth hormone injection every day, it is now possible to have a once weekly injection, and it is even licensed for use in adults. So the first lot that came out was only for children, but there is one licensed for adults. So do have a chat to your endocrinologists if you want to switch. And it's the same price. So the other thing just to be aware of from a growth hormone point of view is that even if you are treated with growth hormone, if you have had radiation to your head and your spine, a lot of your growth during your teenage years is through your spine, and because those bones have been affected by radiation, they won't grow as well as they should do. So you aren't necessarily going to be as tall as you might expect. Your legs will grow, but your back might not grow as well. But we should hopefully still get you within the normal range. And as I say, you do still need a bit of a growth hormone as an adult. And the current recommendations are that it's continued at least until the age of 25 if you're found to still be growth hormone deficient. But ultimately, as an adult, it's your choice as to whether you want to take it or not. So what happens if your thyroid ain't working? So you can have problems with your thyroid because of direct effect of the thyroid itself. So if you've had radiation to your head and neck, it can affect the hormones, the messages that your brain sends down to your thyroid to tell it to work. But also you can get a bit of scatter radiation that sometimes can affect the thyroid. That's less and less of an issue now. We're more and more focused in terms of delivering that radiotherapy. The symptoms of an underactive thyroid are very vague. Most people who have had a lot of treatment for a brain tumour will have massive problems with fatigue. So is this because your thyroid isn't working? Is it because you haven't got enough growth hormone? What about your stress hormones? Or is it because you just feel really, really tired? So it's something it's important that we continue to assess regularly, and it can come on at any time. And you need to make sure that if you're having a thyroid check done, there's 2 parts to a blood test, and GPs can only request a TSH, which is the message your brain sends down to your thyroid. That will tell you your thyroid's not working if there's a problem with your thyroid. But if there's a problem with the messages your brain's sending, which is more common if you've had treatment for your brain tumour, that TSH level is not going to rise. It's not going to be picked up. So it's very important that it's a proper thyroid test that's done. And it's very easy to treat. It's a tablet once a day. And again, these are just showing you your risk of hypothyroidism after radiotherapy, depending on how much you've had. And you can see, so if you've had more than 45 grey, 25 years out, still a third of people have got no thyroid problems. But it is one thing that these things can come on years and years and years later. Puberty. This is the important bit. So normal puberty, anywhere between the ages of 8 to 13 is the first sign of puberty in girls, and the first sign of puberty in girls is you get a bit of breast development. Usually you start your periods by about the age of 15, and boys start anywhere between 9 and 14. So any signs of puberty before those ages or no signs of puberty after those ages are abnormal and definitely need investigating. But what's really important is to know when your mum and dad went through puberty, because the timing you go through puberty is really strongly determined by what your parents did. So if your dad left school at 16, still the class shrimp who wasn't shaving and had his growth spurt when he was 20, you're probably going to be the same. If your mum started her periods when she was 10, well, then you may well be the same. And young people who've had brain tumours may have early puberty, they may have delayed puberty, and they may have puberty that starts and stops, or may have no puberty at all. And it's really important that you monitor and assess puberty and check what's going on. Self-report is notoriously bad. So these are cartoons of the different stages of puberty, just in terms of normal progression. And as I said, the first sign of puberty in girls is a bit of breast development. Pubic hair comes on about 6-8 months later, and you start your period typically around 2 years after the first sign of puberty appears. The first sign of puberty in boys is that their testicles get bigger, and actually it's very difficult to tell. So this is an orchidometer. This is one of the tools of my trade. It is not a nice necklace or a crown, as some of the 2-year-olds come in and wear, that they're very pleased by. And the first sign of puberty is your testicles go from this size to this size, which is impossible to see. And so the only way you can tell is you have to have bead in one hand, testicle in the other, which, if you are a 14-year-old boy, is not necessarily your most favourite thing. Some middle-aged lady fertling around trying to assess your puberty. So I'm very pragmatic about it. And my all-time favourite journal article is one that was published in the Christmas BMJ in 2001, Christmas British Medical Journal. What do you do if you haven't got an orchidometer and you want to assess the sign of puberty? Well, the way you can tell whether somebody's in puberty or not if you haven't got an orchidometer is use a Celebrations Malteser. So a Celebrations Malteser is exactly the same size as an 8mm testicle, or it was in the original article, and back in the early 2000s they were properly testicle sized and shaped. Over the years they flattened them, and sadly, with shrinkflation, they're now only the size of a 6mm testicle. But they do still tell you in puberty. You will remember nothing from today other than Celebrations Malteser. You'll never be able to use Celebrations Malteser again. So cortisol, stress hormone, this is the really important one. If you haven't got enough stress hormone, if you're unwell, you can really collapse in a big soggy heap. So we need to make sure that we're assessing this, we're treating it, that you're on regular treatment, and that you know what to do if you're unwell, and if you're really unwell, that you know how to give an emergency injection. So we recommend everyone carries some kind of ID that says they need to have hydrocortisone in an emergency, whether that's a medical alert bracelet, whether that's something on your phone. And this is a fantastic app which you can download to any phone or tablet, and it's a step-by-step video of how to give emergency hydrocortisone. Everyone will be trained how to do it. It will sit in your cupboard, it will go out of date, and the day you need to do it, you'll go, crikey, what am I supposed to do? So you'll pick up the phone and you'll dial 999 and you'll say, I need an emergency ambulance because my child's at risk of an adrenal crisis, and maybe 3 hours later, if you're lucky, they might turn up. So you're going to have to do it. But yeah, it's very straightforward. So last couple of slides, just going to tell you about what we've been doing in Nottingham. So as I say, we've been here 20 odd years, and I was just doing a quick back of a fag packet calculation in terms of how many young people the team has seen in those 20 years. And I reckon it must be at least 500. And some of those we'll have seen once and not needed to see again. And some of them we'll have been seeing from the age of 3 up until 18, and right the way through to the adult service. And what we did is we set up a one-stop shop, because people have enough time coming to hospital as it is without having to go to yet another appointment. So I do a joint clinic along with my oncology colleagues. And once you've completed your growth and everything else, we do all the testing in paediatrics. So we know whether you need to A, go on to adults, and B, what you need if you're going to move on to the adult service. And we have a dedicated transition service where you go to one specific consultant who knows what they're doing, and then he will follow you up for the rest of the time that you need to be under adults. Although I have to say, he is my age, so we are going to have to train somebody new. And we also have dedicated late effects nurse specialists, who I know everyone's been talking about this morning, and everyone knows how amazing she is. So we started off 3 clinics a year in 2006. So that gave us 18 appointments a year, and we now do 20 a year. This is a measure of how far things have come in 20 years' time, because we only needed 3 clinics, because we didn't see people who had hormone problems, because, to be brutally honest, people didn't survive. Whereas now we're seeing young people, and I'm seeing them go off to university, and it's just fantastic. And as I say, the majority are brain tumour survivors, but we do see other ones. And we also see children who have coincidental endocrine problems. So nothing to do with their underlying diagnosis. They just happen to have another hormone problem. It's like, well, why would you bring you back to another appointment? Of course we can see you at the same time. And this is my final couple of slides. So I just thought I'd start off with a bit of a rogues gallery. So this is who I set it up with 20 years ago. This was David. I think you know, I was trying to find the most youthful picture I could find of David on Tinternet. And so this is roughly 20 years ago. And there's Richard Grundy with his sandy hair. And you can see that actually they haven't really changed at all. You know, that's how they are now. And it was really hard trying to find a picture of me 20 years ago. I finally, because I didn't take any pictures. Well, I was always taking the pictures and nothing was digital, but I managed to find this one. And then I thought, well, that's me now. And then we've got the new generation. So Tim has taken over from Richard and I do the clinic with him. And then once you're too old for us, you move into the joint clinic that I do with Tazo Gaziz. And he will then look after you up until you know, you're 100 or 102. Although since he'll be about 197 by then, he probably won't be him. But yeah, so that's just hormones in a nutshell and what we've done in Nottingham. Thank you.